So denture troubleshooting guide is an extremely important and relevant concept and topic overall because it includes multiple core concepts which can get asked and which are actually asked in the real-time exam questions. Some of the questions are pretty favorite, and prosto section comes with the denture situations, with the denture problems and fixing of it. So this lecture today is about the complete denture situation, not the RPD, but it does apply certainly to the aspect of combination syndromes as well. As we did last week in the Wednesday advanced file class, which is the greatest compilation of the ever coming in the last 4 years, whatever questions came in the exam, the compilation of the last 4-year questions. As we did in the last Wednesday class, I hope everyone here remembers, those who are already enrolled, that we did the prosto section. Is that correct? And I try to bring your attention to the pattern that the combination syndrome and denture problems there was the chief scenario which was asked in the exam. It is the major area where the ADC is asking questions, combination syndromes and problems related to dentures there, right? So we are seeing a pattern there. We kind of put a spotlight on there because once we get aware of the premises around which the ADC is creating questions, it gets easier to prepare those concepts in much more depth so that you're not just mugging up and preparing the only questions that came in the exam, but you also get fully prepared for what new questions can come. So anyone here who can comment here and tell me and let me know that are you only looking to prepare for what came in the exam, or are you also looking to give your 200% and go around the premise and prepare 200% so that whatever new questions also come, you confidently attempt those and 100% increase your chances of a pass in exam. So which approach you are applying to learn, which approach are you applying to prepare? Because that's the Winspert approach, the 200% approach. We don't just prepare what came in the exam, we go above and beyond and we cover the premises and we get 200% prepared. And that's why when we are in that room, in the examination center, the Winspert students stand out. Their confidence, it beams through the corridors, it beams through the centers, and your confidence and the time that you take to attempt the questions. And when you come out, you have revision time, and then when you come out, it's beaming through you. And the same thing gets translated on the result day as well. So that's how we approach. So anyone here who can again emphasize and reiterate on the fact that the last Wednesday class when we did the advanced file and I showed you and we did the prosto questions together, did we see that pattern of the combination syndrome, of the denture troubles, of the denture movements, rocking, and your retention situations? Did we put a spotlight and understood and became aware of that premise? So now it's our duty to prepare above and beyond that, right? So that anything that comes around it, even if the newer questions come, which usually come right after the ADC reaches that stage that most questions get repeated, then a stage comes that the new questions start coming. So we are fully prepared for that situation, and that's why we start discussing the denture troubleshooting guide. This guide has been divided into various sections of the problems that the patient may complain, the chief complaint situation that patient may present, right? So it is divided section wise. What could be the chief complaints? Then what would be the etiology and how would you manage it? So this basically is giving you a cluster of information gathering. The discomfort column covers about how you would find and gather that information from the provided history. What would be the cause and etiology? So it will help you in diagnosing the problem. And then the solution, which is your clinical treatment. So basically all the three clusters here are getting addressed related to the denture questions. So the patient's chief complaint could be a sore spot in the vestibule, upper or lower denture, or a sore spot in upper posterior dam area, post-dam area, which is the posterior limit of the upper denture. Then also it could be a single sore spot on the crest of the ridge. So let's see the first two rows. Sore spot in the deep vestibule and sore spot in the upper post-dam area. So when you have around the peripheries of the denture, the soreness, the redness, that means the overextension of the denture in those areas. So the information that you've gathered from the history would be the redness and pain and inflammation in the extension part of the denture, the peripheries of the denture. So it is overextended borders or some disturbance or some kind of sharpness or roughness in the base of the denture in that area. So it's either the physical extension, which is excessive, or the physical surface of that denture is not smooth and is traumatic. So roughness or sharp edges can lead to that as well. Post-dam has a horizontal extension, which is towards the palate, and also has a vertical extension, which can be too much pressure on the soft palate aspect as well. So post-dam can have two kinds of overextensions, behind it and deeper, both the aspects. So overextension and the roughness and the sharp edges is the cause for these sore spots, and solutions would be accordingly. If it is overextended borders, then you will shorten them and polish them. You will reduce the base carefully, right? Post-dam also you will shorten it if it's extending extra. And then you will also smoothen out the roughness and the sharp edges and then polish the area. So these are the two managements depending upon the two possible etiologies. Then comes your single sore spot on the crest of the ridge. That's a very pathognomonic sign of a premature occlusion as well, when it's a single spot that hurts. We have seen questions like that in the past as well in the exam, and you can expect it to return and be asked again as well. That when a single sore spot on the ridge is seen, a premature occlusion is a very likely cause. Other than that, can be an inaccurate denture based on that particular area. So you will still inspect the impression area as well. And it could have a void or porosity or a nodule underneath it. So again, occlusion or the physical base problem. So if the premature occlusion is the cause, either it could be in lateral excursion or in centric. In both the situations, you will evaluate the centric and you will check all the lateral excursion as well. You will see where the premature occlusion is happening, because a denture, a complete denture, has to be in a bilaterally balanced occlusion. Everyone is familiar with the fact and has attended my full occlusion class as well, where I fully explained bilaterally balanced occlusion, right? When a complete denture is given, it is expected to meet bilaterally on chewing when you have lateral excursions or chewing movements, and one becomes your working side and the other is your non-working side. Is that correct? The side that where patient chews is the working side and the opposite side is the non-working side. Bilaterally balanced occlusion means when the patient is chewing on a complete denture on the working side, the non-working side also should remain in contact. Is that clear for everyone? The lateral excursion bilaterally balanced aspect. Now, other bilaterally balanced aspect is when the patient bites in centric, then the anteriors should meet. And when the patient brings the teeth edge to edge in protrusion, then the posteriors still continue to meet. It's not like in your dentate patient when your mandible will be protruded, your posteriors separate. Is that correct? In your dentate patients, when the patients bring the jaw forward in protrusion, your posteriors separate. Is that correct? It's called mutually protected occlusion, which is seen in dentate patients. But in your complete dentures, do we give mutually protected occlusion or do we give the bilaterally balanced occlusion? What happens in CD or complete dentures, when you bring protrusive or edge to edge, if your posteriors don't meet, then the tipping can happen. Is that correct? Do we desire that? We don't. So a bilaterally balanced occlusion is given in a complete denture in an anteroposterior movement and also in the lateral movements. So on chewing, both sides should meet, and on protrusion, even in the posteriors should meet. How can you maintain the posteriors to meet in a bilaterally balanced occlusion? Upon protrusion, give a deep curve of SPE so that posteriors can move around it and still continue to meet and do not separate. That gives you a bilaterally balanced occlusion. A premature occlusion is anything opposite of that, which means that when a bilaterally balanced occlusion scheme is supposed to happen, prematurely any two teeth up and down are meeting, and which are creating a tipping force or an excessive pressure on a certain area. Is that clear? A premature occlusion lies outside the bilaterally balanced occlusion, right? So basically that has to be eliminated. So you check the bite, you ask the patient to do all the movements, inspect the denture, and you also replicate it on your mounted casts on the articulators, and then you adjust. So a lot of times you may have seen that the selective grinding is done in the mouth, chair side, but that's not correct way to approach. And even in the exams, the answers should not be chair side selective grinding. When you find premature occlusions, then you correct it, mount it on your mounted casts and articulators, remove the dentures, adjust them on the articulators, and then do the selective grinding there. Is that clear for everyone? The ideal management in your patients and ideal answers in the exam should be same, right? Now, the other reason for a singular sore spot could be the base problem, which could be the nodule, anaporosity, or a void. That you will correct by taking the wash impression and rebasing, relining, whatever is needed. If there is a nodule, it's a projection that you will eliminate, remove, and polish. But be careful when you're handling the impression side of the denture because retention predominantly relies on that aspect. Clear for everyone? So far, all the 3 rows and columns, clear for everyone so far? Perfect. Now, because I want you all to leave the class with all these concepts completely visual in your head, and any situation, any chief complaint thrown at you in exam, and you grab it confidently and answer it with your etiology known and with your solution known. That's the agenda of this class. Now, the general overall soreness wash impression is with your very thin flowy material that you take, Samra, so that it is not thick enough so that your impression base is not altered, but it also gives you an impression so you can reline it, Samra, whatever minor discrepancies there in the voids and porosities. Wash impression is with the flowable material, Samra, right? Now, look at the 4th row. What can be the general overall soreness on the ridge? So very predominant reason, and pathognomonic again, please pay attention to this. You can review and revise this class again, okay? So general overall soreness. When the patient complains, I'm sore throughout the ridge and redness throughout the ridge. Not the vestibule, not the periphery, but on the ridge. It's usually the excessive video problem, okay? Or totally inaccurate denture base, which is less likely. Video is the pathognomonic cause there usually, or a complete malocclusion and improper interdigitation, that there is no one premature spot. Entirely the interdigitation, the centric that you recorded of the teeth was inappropriate. That's why when the patient is chewing, there is no perfect interdigitation happening, right? So that's your general overall soreness of ridge. And in the MegaMaster also, and in the previous questions, we have seen questions like that when the question comes and complains of overall soreness on their entire ridges. And then you will have another very important information gathering point there, that patient might say it gets improved once they take off the denture, right? And it's better in the morning, it gets worse during the day because they're wearing the denture during the mouth, right? So these can be two of the associated findings that the patient may tell you. So would you relate those points? Is that clear? So if the video is a problem, then you have to remake the denture entirely or one of them, depending upon if the plane of occlusion is correct or not. If both are wrongly created and fabricated, then you might have to repeat both the upper and the lower dentures. So you will have to correct the vertical. See, reduced vertical can be corrected by adding the base material, the rebasing. But excessive video, you can't trim it down. You have to create at least one of the dentures newly, entirely at a correct video, right? And if there is a total problem with the entire base or the occlusion, interdigitation. So for the base, again, you take a wash impression and try to rebase and smoothen it out and give an accurate base. Or if it's a problem when there is an interdigitation problem, that means malocclusion or improper interdigitation, then for individual types of occlusion problem, you will have to see that when there is a problem with the centric. Interdigitation is a centric relation problem, right? For denture patients, where do you bring your centric occlusion? Complete interdigitation is a centric occlusion. Is that correct? Everyone agrees with that or not? In your dentate patients, your interdigitation is your centric occlusion. In your denture patients, that should coincide with your centric relation. That's what you use at reference for your CO in denture patients. Is that clear and everyone gets that part so far? So CO coincides with CR in your denture patients. What happens? Improper interdigitation in denture patients happen when your CO and CR are not coinciding. You give a centric occlusion in an occlusion point, which is different than your patient's CR. So patient will automatically out of habit bite in CR. And if your interdigitation was not correlated with that, or you recorded your CR incorrectly, this occlusal and improper interdigitation problem will happen, and that will give them pain overall. Right? So again, the management that of this is either you correct it in your teeth setting stage. If not, then you will have to check it on the articulator. Sometimes if it's few teeth, selective grinding may help. But if it's not, you may have to change the teeth setting again. Now, if it's sore under the lower lingual flange, if it's only sore under the lower lingual flange would be in your both bilaterally in your lower dentures, left and right side. So it could be because of, again, centric is off. When centric is off and mastication is driving the denture forward, that means, again, your centric was not recorded correctly. So when patient tries to chew, his natural centric is something else, but denture has been recorded or given a CO in something else. Again, CO and CR not coinciding, there will be some horizontal drag of the denture. Patient will try to drag the teeth forward and try to coincide them. Is that correct or no? When centric is off, centric off means CO and CR not coinciding. In a denture patient, is the CO and CR supposed to be coinciding or not? Yes or no, please. So when they're not coinciding, the patient will try to bring it forward and there will be a drag. Either it will lift your denture off, or what can it cause? It can cause some pain on the ridge also. The ridge will take excessive force. And the lingual flange, especially on that area, extremely thin mucosa, you will get soreness there. Or it could be a physical lingual flange overextension, or that the posterior teeth are placed too far distal. So when the posteriors are placed too far distal, please take off the second molar on that denture. Just give the first molar to first molar relationship. Don't put pressure on the posterior retromolar pad on that area if the mandible is not taking. If the lingual flange is overextended, Inspect that, reduce that, polish it. If the centric is off, then recheck your centric and video, see that your centric occlusion and centric relation are coinciding, re-articulate it, remove the interfering cusps and change to the non-interfering teeth. So selective grinding, but ideal answer would be chair side, or ideal answer would be on articulator. What would be answer? Whenever you're correcting the interferences, centrics CR not coinciding, you will be having to manage by selective grinding. It would be done on the articulator. If it is identified in the wax trying stage, you will correct it again on the articulator by adjusting the teeth, right? But once the denture has been fully made, then the selective grinding has to be done, right? So depends on it at what stage the patient complains and the identifies. Now, sore under the lower labial flange. So lower labial side flange, again, one very important reason is too much overbite. When the patient's overbite is excessive, then also labially they can start hurting. Or overextended flange. Or again, when masticating, patient is throwing lower forward. Again, when does the mastication throws the denture forward? When the CO and CR are not correlated, right? And not coinciding. Is that clear? Every time you look at the statement in the patient's presentation of that sore under the labial area, it's sore in a particular area, especially posterior, where the centric is supposed to happen, and my denture also moves forward. You know that COC are not coinciding. Does that visual get recorded in your head? Would you remember this? Pain in the posterior part, in the molar areas, and denture moving forwards. Is your COCR not coinciding? You will have to rearticulate and selectively grind. Now, burning sensations. If the patient's chief complaints are the words burning sensation, then burning feeling on hard palate or on lower anterior ridge is because, so burning sensation is patient's way of telling that there is excessive pressure. When the patient uses these terms, you should understand the cause is the pressure in that area from the denture. So it's impinging the nerves. So burning feeling on hard palate or on lower anterior ridge, pain is separate and burning is separate. So when burning, it is causing excessive pressure. High pressure is identified by using pressure indicating pastes and then relieving those areas. Simple. Locate that high point by using a pressure indicating paste, remove and polish. Burring on the bicuspid area to the tuberosities, again, high pressure in that area. Same as above, grind the entire area which is in high pressure. How? By using the pressure indicating paste. Burning feeling on upper anterior ridge. Upper anterior ridge burning can be pressure on the papilla and the rugae area, which needs to be relieved. So check whether this area has been provided the natural relief during the denture fabrication or not. If not, use a pressure indicating paste, identify and relieve those areas. Clear for everyone? The term burning feeling whenever given, how will you manage it? Now, biting cheeks and tongue. So cheek biting and tongue biting also is a very frequently reported chief complaint. How will you manage that? So keep biting cheeks or tongue. Whenever the cheek biting or tongue biting is happening, there is problem with vertical or with the horizontal overlap of the teeth. So when the posteriors are set to edge and there's a lack of overbite in posteriors, it tends to bite. How will you adjust it? You will reset, rearticulate, and you might have to reduce the buccal surface of the mandibular molars a little bit to create the overbite. Overclosed denture means excessive deep bite, right? Overclosed is excessive deep bite. So you will reset all the teeth and try to open the bite or reduce the anterior overbite. So posteriorly edge to edge bite and anteriorly deep bite both can cause the cheek biting and tongue bite. Posteriorly, also when the teeth are offset of the crest of the ridge, too far buccally or too far lingually, then also it can lead to the tongue or cheek bite. So mandibular posterior teeth should be set on the crest of the ridge. Now, what can be the other problems is the redness of the tissue. Complete inflammation and redness. Tissue getting red in denture bearing area. So one of the most important red denture bearing area picture that you get in the exam, everyone has seen that question, that is BQs, multiple quizzes on that question with red palette. TG has a beautiful picture on that. I don't know if beautiful is the appropriate word, but yes, very wonderfully observable red palette is atrophic denture stomatitis, right? Number one. And the predominant cause of the same is Candida is the causing factor, but the etiology comes from the poor oral hygiene of the denture. Poor denture hygiene, wearing of denture during the night. These are the predominant cause of atrophic denture stomatitis. And one of the most favorite topics, the core concepts in ADC. So make sure word for word you know it. In the class with the advanced file, we do the Newton's classification for the candidiasis as well, denture associated stomatitis. Is that clear? Everyone who's still reached that stage or not in the Mega Master, the Newton's classification, the inflammatory papillary hyperplasia stage, the atrophic stage, all the stages of denture stomatitis are important and get asked in exam. So other than that, causes can be ill-fitting denture base, improper curing, avitaminosis. So take a wash impression and rebase if the denture base is an issue. And if the vitamin deficiency is there, identify it and then send to probably to the medical specialist and let them handle the deficiencies and manage. But for dentists predominantly, it's the deficiency of vitamins. All tissues becoming fiery red, including cheeks and tongue, that would be extremely rare, but it would be coming from denture-based allergy. True acrylic allergy is extremely rare, right? But if a patient is identified and has been proven to be truly allergic to the acrylic component, then there are acrylic-free dentures available you will use for them. But you will have to confirm the patient that they have the true allergy or not. Other problem with the denture wearing patients can be pain in their joint, right? So pain in the TMJ. Pain in the TMJ can be because of vertical overclosed, right? Which is too little video. Can also be because of trauma, arthritis, and again, even centric when it's off can put the load on condyles, can also present as mandibular pain. So when you have vertical overclosure, excessively deep bites, which is putting the load on your condyles, you will rearticulate and open the bite slightly and reset all the teeth. So vertical has to be corrected, the deep bite. And when the centric relationship is off, that's putting the cause on the condyles, then again, you will have to re-evaluate where the centric is, record it, and reset the teeth in your exact centric relation. Arthritis, of course, you will have to make the correct recommendations to the medical specialists. Even trauma, again, the specialist management. Now, one of the very, very commonly asked situations in the denture problems is the instability. Instability, patient complains of looseness of dentures, either in function or on chewing, or he can say even at rest. So when not occluding, that would mean on rest. When chewing food, that would be on working side, on lateral excursions, or when occluding in centric, that means when he is biting on the centric occlusion, the maximum interdigitation. Let's see how the three situations in stability are caused and how they will be managed. So when not occluding is a rest problem. Mostly the rest looseness comes from the generic problem in the fabrication, the retention situation. So either it is overextended or underextended. Both lead to the lack of retention. Yes or no, please? Then the lack of post-dam also leads to lack of retention. Even dehydration of the tissue will not create that seal that comes from the saliva, right? Between the mucosa and the denture. And flabby tissues which are displaced when taking impression due to improper tray. So if a patient has a flabby tissues, where do you see flabby tissues patient? One of the ADC's most favorite complete denture patients. Flabby tissues. Very classic sign of a combination syndrome. And then ADC repeatedly asks you what kind of impression you will take. So the custom tray with the windows and the flowable PVS, is that correct? Have been doing this. We did this only last week, all the concepts. It is all interrelated. So all these are the problems when the denture will be loose even during the rest, overextension, underextension, lack of post-dam seal, dehydrated tissues or flabby tissues which have not been recorded correctly. In all these situations, you will require a new impression, whether overextended, underextended. You will have to do the border molding again, rebase also if the extensions or post-dams are not correct. Excessive video cannot be grinded. Where are you going to grind? 1.5 mm denture, by grinding what part can you grind? Excessive video, you'll grind 1.5 mm teeth. Can do that, right? Excessive video has to be rebased, or one of the denture, it can't be rebased also because rebasing is adding material. It will add on to video. It will have to be done by creating a new denture, either one or both, depending on your occlusal plane, but you can't chop off the teeth by 1.5 mm. Now, when and even slight excessive video is identified by the patient with the pain and discomfort. So there's only a limit of 2 to 4 mm of freeway space that a patient can physiologically accept. Anything below than that, patient will have a constant load on the ridges and a discomfort, right? Well, that should have, well, because the freeway space is 2 to 4 mm, and if it's really to the border of that, then it's actually not excessive video. If it's still within those freeway space limits, then yes, you can selectively grind few teeth. But if that accommodates, I would say then more than VDO, that should be like an excessive or occlusal interference. But if it's an excessive VDO beyond the beyond your physiological tolerance, then if you reduce the denture base area, you will alter the impression site. So you have to recreate, refabricate. Now, coming to when chewing food when the denture gets loose, it is because, again, during chewing, the most important cause, which is not here in this article, is the lateral excursion, lack of bilaterally balanced occlusion during lateral excursions. Not mentioned here, but the predominant cause, looseness during function, is lack of bilaterally balanced occlusion, especially when the patient say, when I try to chew food on one side and denture rocks on midline. Denture rocking on the midline means that chews on the one side and the other side comes down. Yes or no? That is your chewing food looseness. Denture rocking on the midline is because of your interferences in your lateral excursion, right? So you will correct the occlusal interferences and make sure your denture is bilaterally balanced even on your sideways chewing. Working and non-working side, both contact. It can also be because of the post-dam seal, anterior teeth which are too far labially, flabby anterior tissue which has not been recorded correctly, only then it will rock. Improper incising habits, lower posteriors when they are set off ridge. So based on the problems that you may identify, Again, occlusal problems, resetting, remounting, right? Patient education if there is a habit issue. And flabby anterior tissue should be recorded with your correct technique. Now, when the denture is loose, when the patient is occluding in centric, is again the bilaterally balanced occlusion missing during your centric relationship. So prematurities would be there. High occlusion can be on either one side, or some area would have a premature contact. Again, everything, any malocclusion, any prematurities will be addressed on the articulator and with your selective grinding. Then upper denture riding on the hard palate surface. So if there is a pressure, again, use the pressure indicating paste and relieve the area. Flabby tissues, either record them correctly, or if it's causing a problem to the patient also, you can surgically remove as well. Then teeth arrangement should be assessed. Now, other problem is interference. Sorry. Interferences when swallowing. So when the swallowing is associated, it's mostly involved in the posterior aspect of the dentures. In upper, it would be involved in the buccal flanges, and lower, it would be involved of your overextension of the lingual flanges. In both the situation, check the overextensions and reduce the thickness if it's over thick also. Other cause of swallowing problem is, again, deep bite or too much video, or posteriors which are too far lingual and crowding of the, which are leading to the crowding of the tongue. So identify the problem. If it's overextended or over thick, reduce the extension, reduce the thickness. If it's too much vertical and leading to the swallowing problem, then again, excessive vertical has to be addressed by refabricating. Gag comes from post-dam areas or the glossopharyngeal nerve irritation. Post-dam areas can lead to the gag by overextension, or distolingual flange would be too thick and it is reaching your pharyngeal muscles, leading to gag again. Both would be leading to immediate gagging upon insertion of the denture. So you have to improve the post-dam area, and if it's coming from mandible distolingual flange, you have to correct it so that it doesn't impinge and irritate your pharyngeal muscles, right? But if the gagging is reported few weeks to months after, a delayed gagging coming from a denture is come from a fact that a saliva is pooling under the denture, and a malocclusion is leading to the denture loosening, which causes again saliva to pool under the posterior part of the denture. So that's a delayed gagging. Delayed gagging, you should inspect the post-dam area, whether it's loose or not. And you might have to rebase, add the material there so that saliva doesn't get seeped in and get pools there. So immediate is the overextension or thicker borders, and delayed gagging is coming from a post-dam looseness, right? Or a malocclusion or an interference, which is again lifting the denture in the post-dam area. So cause of delayed gagging is saliva seeping through. Again, this question has been asked in exam. Delayed gagging, how will you manage? Options were given: antiemetics, checking the area in the post-dam, and rebasing it. What do you think should be the correct management if your patient reports gagging after few weeks of denture insertion? Would you give him antiemetics? Or would you inspect the post-dam area that saliva gets seeped in and pools there? That irritates the patient's palate and leads to the gag sensation. So you will correct the post-dam, correct the retention, and rebase it or reline it, right? Do not handle those by antiemetics. This is a very well asked question in the exam. Now the problems can be with aesthetics and phonetics as well. Let's talk about aesthetics. It can give you a bulky appearance under the nose or a very sinking appearance under the nose. The lip can also be too much sinking. So too bulky means the labial flange is too thick or the teeth are too out. So reduce the flange thickness or set the teeth internally. If it's too much sinking, that means the teeth are too in or the flange is too needs some bulk, so add the bulk. If the lip also sinks too far in, again, the teeth are set too far lingual, so bring them labial and bring the labial prominence in the patient. Sometimes the aesthetic problem can be showing too much teeth on smiling. So the vertical is too great. If the vertical is too great, teeth height is too great, you're simply reducing it will not help. Again, you will have to correct the vertical. Or sometimes the upper teeth are showing too much because your plane of orientation, your occlusal plane was set too low. So try to balance it. Plane of occlusion should be set in the center. Then cuspids and laterals may be too prominent, correct them. Or anterior too far labial, correct them. Or just it gives a very artificial or a false appearance. Again, you need to select the teeth based on the patient's facial appearances. The shades also should have some natural look to them and some contouring and some natural characterization should be done when teeth setting. Now the phonetics predominantly comes on the S sound, t and the sounds, and f and v sounds, right? So the s sounds, I have two situations, whistling or lisping. The whistling comes when there is not enough room for tongue between upper bicuspid. So when the teeth are set too narrow in the canine area, right, or the premolar area. If teeth are set too narrow in the premolar area, it will lead to whistling. Solution, reduce the teeth surface from the lingual aspect in the premolar and create room for tongue, right? Remove or move the bicuspids more buccally or grind that area, but create room for tongue. Other reason for the whistling on S could be space between the centrals. So mind that space and fill that space. Second S sound situation is the lisp. The lisp comes when, yes, it's the upper bicuspids, the upper premolars area. Now the lisp comes when the tongue slips through the area. Again, it's the bicuspid situation, but when there are too much space. So whistling happens with the too little space for the tongue in the bicuspid area in the upper, and lisp happens when the tongue slips, and because that would be too much space in the premolar. So then you try to bring premolars slightly lingual, right? And if it's whistling on the s sound, then take the premolar slightly buccal. Would you remember this? Whistling when it's too narrow, take them buccal. Lisping when it's too wider, bring them lingual. Would you remember this visually? So narrow the palatal space when there is lisp and widen the palatal space when there is a whistle. Simple. Now, the and t sounds, sometimes they can be t and the sounds patient makes same sound or it sounds alike when they're trying to say the same different sounds, but they sound same. That's when anteriors are placed too far lingually, so internally. Then t and the sound will be sounding alike. So you have to take the teeth slightly labial and create the room for the tongue. F and V is the vertical incisal situation between the incisal edge of the teeth and the lips. So F and V sound is the vertical problem of the upper anteriors with the lip, either horizontally or vertically. So adjust the bite and the overjet, right? So improper position of the upper anterior. Upper incisors make F and V sound when they meet the lower lip. So too far anterior, too far lingual will cause F and V problem, or too far below or too far above without inappropriate deep bite or the overbite again will also cause. So check the anterior incisors in the maxilla for their horizontal and vertical positioning to check the F and V sounds. Clear for everyone? T and the sounds are when Anteriors, upper anteriors have been placed to lingual. So take them buccally, right? Give them a horizontal overjet. Yeah, palatal, right? So when anterior or the lower also are placed lingually. So then the tongue is constricted between the anteriors. So take the anteriors slightly labially. That's your t and the sound. F and v, only upper anteriors, vertical and horizontal, overjet and overbite, you correct. Will you remember? Lisp versus whistling, will you remember? Narrow, whistling, widen it. Lisping, it's slipping, narrow it. F, anterior, vertical. T, the anteriors are too far lingual, bring them anterior, right? Aesthetics were very pretty simple. Then denture moving forward, there is a drag on the denture, centric occlusion, centric relation not coinciding. Posteriors will turn red, soreness on the posteriors, pain in the posterior area. Gagging, which is delayed, right? Then lateral excursion, midline rocking, right? Particular spot redness and pain, premature occlusion. Will you remember these key points now? Anytime a patient says a specific history, presents a specific chief complaint in your dentures, do you feel confident enough to even identify, get a cause, and then at least know the possible solution? Yes or no, please? Because that was the full agenda of this class, so that you can leave confidently. And if you've not joined the course yet, please make sure that we discuss every single concept in depth with this clarity in our live classes and in our weekly webinars also. So please join if you haven't. But this is how we take every core concept, dissect it, break it down, prepare it above and beyond 200%, and get it right in exam. Is that clear for everyone? Whistling is when teeth are too narrow. So teeth are, bicuspids are placed too much towards palatal. And lisping is when the bicuspids are placed too much buccal. To balance that, in whistling, you will take them slightly buccal. And for lisping, you will take them slightly palatal. Navneet, I hope that's clear now. And you can completely visualize it. When you try to whistle, you narrow your mouth, right? Naturally, when you try to whistle, you have to narrow your arch. So when whistling is happening by speaking, that means the denture teeth arrangement has been narrowed. I hope that makes sense now, Navneet, right? So I hope you had a full visualization of the concepts of this. This sounds like a very small document, but a full 1 hour discussion on this and you're sorted, right? So that's what we want to be with all the core concepts for ADC. That's the preparation you need to clear the exam, not just by fluke, but by surety and confidence. So that's what we do at Winspert. It's not about fluke. It's not about, okay, let's see how the result goes or how the paper comes. No, it's about handling the concept so confidently that external situations come what may, you are 100%, no, 200% prepared for the exam, right? So I'll see you